I'm going to do a brief overview of the drugs in chapters 16 through 18, beginning with the salicylates. As you have read in your chapter, the inflammatory response protects our body from injury and pathogens, and there are several conditions that can cause the immune system to function inadequately. We are going to talk about one of these inflammatory responses, which is related to arthritis. There are many types of drugs that impact the inflammatory response, and the sites of inflammatory agent action is described in a chart in chapter 16. The salicylate example that we're using is aspirin. It inhibits prostaglandin synthesis, which causes the inflammatory response. It blocks prostaglandin mediators of the pyrogens in the hypothalamus and acts to reduce fever as an antipyretic. And it can also act as an anticoagulant by inhibiting platelet aggregation. Adverse effects of salicylates include heartburn, dyspepsia, nausea, and occult blood loss, which impacts the cardiovascular system by a decrease in hemoglobin and hematocrit and decreasing the oxygen carrying capacity. High doses can cause a condition called salicylism, which includes dizziness, ringing in the ears, difficulty hearing, some mental confusion, and GI upset. So the lowest dose of an aspirin possible should be used. Children who have chickenpox or influenza or other viral syndromes should not take a salicylate due to the risk of Reye syndrome. And all salicylates should be administered with food to alleviate some of the GI effects. NSAIDs, the examples that we used are ibuprofen and ketorolac. Generally for this class, they inhibit prostaglandin synthesis. They also have an antipyretic and anti-inflammatory effect. Therapeutically, what we anticipate seeing from a patient who takes an NSAID is a decrease in their pain level. So they're given for inflammation, pain, fever, muscle aches, arthritis, and ketorolac is typically given for moderate to severe pain after a surgical procedure. It is given IV, typically in the PACU, and the oral is given only as a continuation of that IV for a short period of 3 to 5 days. These drugs, the main adverse effect would be GI and an increase in GI bleeding. So they're contraindicated for patients with peptic ulcer disease, a history of GI bleeding, and need to be used in caution with patients who have liver or renal impairment because of the body's inability to metabolize and excrete the drugs. They should also be administered with food to decrease that GI upset. As a related agent, acetaminophen acts on the thermoregulatory cells in the hypothalamus to decrease fever. It's typically used for fever, but can also be used for pain. It can be given for fever to children who have influenza. It can also be used after a vaccination, and patients with arthritis may use acetaminophen to treat their pain. The major complication would be renal and liver toxicities with large doses. The maximum dose of acetaminophen is only 4,000 milligrams a day, and there is an antidote that is given for patients who exceed that 4,000 milligram max in a day called acetylcysteine, and that is the antidote, so please remember that is given to counteract the negative effects of the acetaminophen on the liver, so it slows the liver damage that occurs with an overdose. Note for you to remember is that acetaminophen is found in many over-the-counter products, and also in some oral pain medications. So you need to be careful to note the amount of acetaminophen found in the other agents you're giving along with the plain or extra strength acetaminophen. Another anti-arthritis agent are gold compounds, and auranopin is the gold compound highlighted in your textbook. It helps to prevent some arthritis and synovitis that occurs as a part of the anti-inflammatory process in the joint. It is typically given to patients with rheumatoid arthritis, or RA, who have not responded to other arthritis medications. It does not it can prevent further damage, but it doesn't repair the damage that's already there. There are several severe toxicities that are related to this drug, including nephrotic syndrome, bone marrow depression. It can cause dermatitis, and patients can develop nausea, vomiting, and stomatitis, which is inflammation of the mucous membranes of the GI tract. Because of the many contraindications, it's not given frequently, and individuals who are placed on gold compounds need to know that it takes about 3 to 6 months to see any effect in decreasing their pain. Disease-modifying anti-rheumatic drugs, or DMARDs, adalimumab and etanercept are the two examples that we've included this semester. They typically inactivate the leukocytes to reduce the inflammatory response and prevent joint damage. Both of these drugs are used to decrease the progression and signs and symptoms of severe rheumatoid and psoriatic arthritis. Adalimumab is also used for Crohn's disease. The adverse effects will be immune response because they reduce the immune response in the body. They increase the patient's risk of serious infection. Typically, patients who have been exposed to TB and other major infections are not started on these drugs, so they may often either ask you if you're the patient, if you've been exposed to TB, or they will do a TB test, because the risk of developing a full-blown case of TB is very high in use of these drugs. They can cause some cancers, they can cause some cardiovascular effects, myocardial infarction or heart failure, and typically you can get a local site reaction from the subcutaneous administration. These are very expensive drugs, and they're used cautiously because of their risk for serious infection. A couple of herbal supplements whose results are inconclusive have been prescribed for patients with arthritis, and they are glucosamine and chondroitin. They are thought to block the enzymes that break down cartilage and cause joint discomfort, and they're typically given together as a supplement. But for individuals who are diabetics, they may worsen your glucose control, and if given with anticoagulants, they increase the risk of bleeding in these individuals. So they need to be used with caution with patients with heart disease and diabetes. Chapter 17 discusses the immune modulators. Interferons are immune stimulants who inhibit the growth of tumor cells and enhance the immune response. They are typically given for individuals with leukemia or melanomas or Kaposi sarcoma. They can cause blood dyscrasias, blood marrow suppression, flu-like syndrome, so the aches and pains that you feel like you have the flu, some dizziness or confusion, and patients may have anorexia or nausea. They're given subcutaneously for these individuals. Colony-stimulating factors include filgrastim, which is used to increase the production of the neutrophil in the bone marrow. It's typically given to patients to help them recover their neutrophils after chemotherapy, for patients with leukemia, or after a bone marrow transplant. Bone pain is a very common adverse effect of a colony-stimulating factor, and patients ache like they have the flu. So you need to teach them to anticipate bone pain, because most patients do have that. Other patients may have some GI distress or headache and fatigue to go with it, but bone pain is the major adverse effect that is common. How do you know it's effective? You monitor the CBC to see if there are an increase in the number of neutrophils with the sequential CBCs. An immunosuppressant that is commonly prescribed for patients to prevent rejection in transplants is cyclosporin. Its adverse effects include gum hyperplasia, bone marrow suppression, and in the central nervous system, patients can develop tremors. It's used with caution in renal and hepatic disease to the increase of these renal and liver toxicities, and those are the labs that need to be monitored to identify any issues. Review the items listed here on the chart and think about the desired outcomes of all of the medications that we talk about this semester. When you give the drug, what is it that you expect to see as an effect, and what are the complications and safety issues you need to teach your patients? Chapter 18 goes into detail about vaccines and immune sera. I just need you to know the difference because you're going to talk about these in more detail in your PEDS course. Vaccines are immunization containing weakened or altered protein antigens that are typically, examples would be your measles, mumps, rubella immunizations, your influenza immunization, zoster. The most common adverse effects are flu-like symptoms of fever, aches, and chills for a couple of days, and local pain and redness reactions. Some patients may exhibit some central nervous system reactions, but they're not as typical. Individuals who have an allergic to eggs, who are taking corticosteroids, who have had blood transfusions within 3 months prior to vaccination should not be given a vaccine. For children who receive a vaccine, they should not receive aspirin or an NSAID for immunization discomfort because it masks the warning signs of Reye's syndrome, which is a complication that children may develop. Immune sera contains antibodies to specific bacteria or viruses, and examples of these are hepatitis B vaccines and the RHO immune globulin medication that's given to women after delivery. You need to monitor for adverse effects including serum sickness, and vaccines are used to prevent infection with future exposures. They are not used to treat an acute infection. Look at the focus on the family or focus on drug therapy across the lifespan, the patient teaching about immunizations that you find in your text.